بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سعيدين to start sessions about breast diseases. It's actually going to be in 3 sessions. Session 1 will be about benign breast disorder. Session 2 and 3 about breast cancer. And the commonest condition that we are going to cover with respect to benign breast conditions are fibroadenoma of the breast, fibrocystic condition, nipple discharge, traumatic fat necrosis, and breast abscesses in lactating and pregnant women. With respect to fibroadenoma, it is the common benign neoplasm. We see it so frequent. Young female, usually around puberty, and it is very common. Diagnosis is very easy, as you are going to see in the clinical presentation, and usually it is one that's being discovered accidentally, but sometimes in 10 to 15% might be multiple. We call it multiple fibroadenomata rather than fibroadenoma. Fibroadenoma for a single lump. 2 or more, we term them fibroadenomata. The typical presentation is that of small, rounded, discrete mass, rubbery, and not tender. It is in the size of 1 to 5 centimeter in grits diameter. Sometimes might be a bit larger, and it's easily to be diagnosed clinically, but it should be confirmed before sending patients home. It's usually called breast mouse because it is free mobility, and breast mouse is a characteristic of this condition. Usually discovered accidentally, or sometimes patients might be in during shower or very minor trauma that he tried to feel and he found a mass. Clinical diagnosis is generally not difficult. As we mentioned, that young female, mobile mass, discrete. If the patient is over 30, then we have to consider other differential diagnosis rather than fibroadenoma, although in all cases we have to confirm it's not only just clinical examination, but as well we have to confirm it by tissue diagnosis through cut needle biopsy. It is not after menopause, unless the patient is being taken hormone replacement therapy. Otherwise, due to evolutions of breast glands in elder women and the absence of estrogen is unlikely to be seen in such age. Clinical diagnosis, we feel it as a lump, but we have to do some sort of investigation to make sure whether this is really a fibroadenoma or a cystic condition. An ultrasound will differentiate this. Treatment, if it is proved to be fibroadenoma by tissue diagnosis through cut needle biopsy, then no treatment actually, unless the patient is being annoyed for the lump to be removed. But if it's being confirmed, one can still sit on it, and most of the patients, their fibroadenoma will disappear with time. But if it gets increased in size, then it's time for removal. Excision, if the diagnosis is uncertain, and excisional biopsy, it is excisional biopsy for histopathology is treatment and diagnosis. Cryoablation has been an attempt to treat fibroadenoma rather than excision, and it's not being practiced. This is one variant of fibroadenoma. We call it Phyllodes tumor. Phyllodes tumor is a fibroadenoma-like tumor, but here the Serous tumor grew very rapid. Otherwise, clinically, it's more or less like fibroadenoma but a bit larger. Not possible to distinguish from a large fibroadenoma. Clinically, they are smooth, discrete, rubbery, mobile. But Phyllodes tumor might reach a very huge size. It may reach a large size, and if inadequately excised, will recur, and this is one of the problems of Phyllodes tumor. Phyllodes tumor can be benign or malignant, and we have to differentiate between the two, because malignant type of Phyllodes tumors needs adjuvant chemoradiation after, and in either case, if we suspect it, we have to take it with a removed safety tissue. The lesions can be benign or malignant. Complete removal with a rim of normal tissue avoid recurrence. You don't know from the start whether this is Phyllodes tumor benign or malignant. You might have histopathology after trochlear biopsy as Phyllodes tumor. But the complete diagnosis in some cases might be after excising the whole mass and send it back for histopathology. Therefore, for safety and courtesy, we have to take a ring of normal tissue around safety margin. Simple mastectomy is sometimes necessary in very large Phyllodes tumor that occupy the whole breast. Then we have to take it. The most important point that I would like to stress, fibroadenoma, usually if we do mastectomy or breast conserving surgery for malignant Phyllodes tumor, there is no need to go for axillary resection, because malignant Phyllodes tumor, it is sarcomatous types of tumor, usually metastasized to the lung and not to lymph nodes. Fibrocystic condition is the second condition that we confronted with this during our daily work, and in some countries fibrocystic disease comes number one, but here in Sudan fibroadenoma is number one, followed by fibrocystic disease, and it is estrogen is a causative factor for this, and therefore still this is a disease of young and 20 to 30 years after puberty. The macroscopic findings include fibrosis, as from the name, fibroadenosis, and adenosis as well, and there is some microscopic or cross cyst that can be seen, papillomatosis, and ductal epithelial hyperplasia. All these types of elements are found on fibrocystic disease. Only the variant with atypia represent the true risk factor, and one should be aware whenever there is suspicious of fibrocystic disease of the breast and trochlear has been taken and the histopathology report came back as a fibrocystic disease with atypical cell, then you have to be aware and you have to excise this mass. Fibrocystic in general doesn't need surgical excision, but if there is atypical cell presence, then we have to remove the lump. Why? Because this is a risk factor for development of breast cancer. We don't want to put patients with the risk of developing breast cancer. We have to take it out. The clinical finding, asymptomatic lump as fibroadenoma that's being discovered accidentally, but pain and tenderness often call for attention, and usually pain of fibrocystic disease had an association with menses. Premenstrual tension was very safe. This is normal in some females, but we associate with breast pain, and even during menstruation, not only pre-menstrual tension. Point number two, discomfort. Why patients develop such pain? Because the cyst will get enlarged. Other points, nipple discharge, and this nipple discharge is not bloody at all with fibrocystic disease. Might be green, might be yellow. And there's transient lump. Transient lump or fluctuation in size, or the patients might tell you that there is a lump that I will feel in my upper outer quadrant, and sometimes both breast, upper outer quadrants. There is a lump that has been felt during menses, and later it disappears or reduces in size. And with each cycle, this definitive lump will get increased in size and then reduce after. This fluctuation in size is typical of fibrocystic disease. Other features, fibroadenosis might be multiple or bilateral, and this is the commonest. The commonest are bilateral in the upper outer quadrants. Diagnostic test. FNA is usually diagnostic, but it's not conclusive, like core needle biopsy. FNA, if it's being done in good hands, a very eminent cytologist that's able to interpret the cytology, the sensitivity might be up to 90 plus. Excisional biopsy, if it doesn't resolve over several times, then we have to excisional biopsy, surgical excisional biopsy. Surgery should be conservative. In this case, this is benign fibroadenosis. We have to conserve, and the objective is to exclude cancer rather than to mitigate as the cancer itself. Differential diagnosis breast carcinoma is number one, but the pain associated with this condition, fluctuation in size, and multiplicity make them features that can differentiate fibroadenosis from carcinoma. But if a dominant lump is present, then cancer should be in mind till proof otherwise. Final diagnosis depends on excisional biopsy, mammography, and sonography. This is mammogram. We have to take two views, oblique view and superior view. And usually we do mammography for women above 35 years of age. Below that, we do ultrasound, quite enough. And this is a mammogram. This is a normal architecture of the breast. There is no any lump here seen or cyst. And this is fibroadenosis. This is fibroadenoma, very smooth outline. This is cyst. Treatments of fibroadenosis, aspiration of a discrete mass suggestive cyst is indicated to alleviate pain. If the ultrasound showed that the lump is cystic, then we have to aspirate it. An aspiration will resolve the pain and confirm the cystic nature of the mass. Mass persists after aspiration or during follow-up should be excised. Breast pain is best treated with medication. danazol, tamoxifen, stop hormone replacement therapy, eliminate caffeine, and giving vitamin E. We have to avoid trauma. Wearing support for the breast give protection and reduce pain. Topical gel may be of value. Danazol orally 100 to 200 milligram twice daily. This synthetic androgen is being given for severe pain, but is rarely used because of the side effect: acne, edema, hirsutism. It's not advisable right now. Tamoxifen, this is estrogen, anti-estrogen drug, reduce some symptoms of a persistent condition, and it is not usually very fair for young women because of the side effect, and it's given to reduce the risk of cancer. Postmenopausal women receiving hormone replacement therapy may stop hormone to reduce the pain. As well, eliminate caffeine from the diet. يعني chocolate, tea, coffee. If you eliminate caffeine, it's been found that this will reduce the pain. Vitamin E, 400 international units daily, reduce the pain, but support and non-steroidal anti-inflammatory gel will usually enough for the pain. Prognosis, exacerbation will occur at any time until menopause. Breast self-assessment after menstruation for masses. The risk of breast cancer is high if there is atypical cell. I usually follow up with physical exam and ultrasound in young female and mammogram in those above 35. Nipple discharge is also one of the commonest benign conditions that we see. And differential diagnosis of nipple discharge: duct ectasia, intraductal papilloma, carcinoma. These are the commonest and usually discharged in non-lactating women. There is certain questions that we should ask and features to look on physical examination in order that we can make the diagnosis. Number one, we have to make sure what is the nature of this discharge. Is it bloody? Is it serous? Is it milky? Is it green? Is it yellow? Again, is this discharge associated with a mass or not? And it is coming from one breast or both bilateral. As well, we have to see if it is from one or both breasts. Is it coming from a single duct or multiple duct discharge? Whether it is occurring spontaneously or after we press on the lump or the site. And pressure on a single site or general pressure on the breast. Again, relation to menses. And whether the patient is pre or postmenopausal, and is the patient taking oral contraceptive pill or estrogen. These are important points to consider in any patients with nipple discharge. Is it there is an associated mass with the discharge? Is it bloody or not? Unilateral, multiple orifices, spontaneous, pressure, taking pills. Serous or serosanguineous discharge. Unilateral, spontaneous from a single duct, usually caused by intraductal papilloma, and rarely by carcinoma. A mass may not be palpable. Patients with nipple discharge, you might not feel a mass at all. The involved duct may be identified by pressure at different sites around the nipple at the margin of the areola. And usually they are coming from the ducts. Bloody discharge, one should consider breast carcinoma till proof otherwise, although benign papilloma is common. And usually we can differentiate between them easily by doing a exfoliative cytology, bloody nipple discharge for cytology assessment, whether there is malignant cell or benign cell. Differential diagnosis breast carcinoma is number one, but the pain associated with this condition, fluctuation in size, and multiplicity make them features that can differentiate fibroadenosis from carcinoma. But if a dominant lump is present, then cancer should be in mind till proof otherwise. In premenopausal women, spontaneous multiple discharge, unilateral or bilateral, just before menstruation is usually due to mammary dysplasia. In this case, the discharge may be green or yellow or brown. Duct ectasia, usually seen on biopsy. If a mass is present, it should be removed, but sometimes you might not be able to feel it. Milky discharge, and this is usually, if the patient is not lactating, is very likely due to hyperprolactinemia, and it's commonly occur from different ducts, and we have to assess the prolactin level in the blood, serum prolactin, and TSH to exclude hypothyroidism. And if the patient, whether he's taking antipsychotic drugs or not, I know some of the psychotic drugs might cause milky discharge. And this discharge will disappear or stop in discontinuation of the medication. Oral contraceptive pills or estrogen may cause clear serous or milky discharge from a single duct, but multiple duct discharge is more common. If none stop from a single duct, then we have to explore. Purulent discharge, usually due to abscess. We have to reassess patients every 2 to 3 months for a year. Mammography should be done if greater than 35. Localization is not possible sometimes. No mass is palpable. Discharge is non-bloody. Then we have just to follow the patients if any of this is the condition, if there is no palpable mass and no discharge is bloody. Most discharge is from benign process, but annoying to the patient. To eliminate the discharge, proximal duct excision can be considered for post-treatment and diagnosis. Exfoliative cytology may rarely be helpful in diagnosis, but if the cytologist is very expert, can differentiate benign from malignant, as we mentioned. Catheterizations and lavage performed to evaluate cell for ATPM. Traumatic fat necrosis is very important because the clinical presentations of traumatic fat necrosis is more or less similar to that of breast cancer. Patient might present with mass, nipple retraction, fixation, mass hard or firm, and but a history of trauma is very important, and trauma should be severe enough to disrupt the fat cell. But in few patients, they cannot remember history of trauma. Trauma is presumed to be the cause, though only 50% of patients give history of injury. Ecchymosis occur if trauma is recent. There is certain questions that we should ask, and features to look on physical examination in order that we can make the diagnosis. Number one, we have to make sure what is the nature of this discharge. Is it bloody? Is it serous? Is it milky? Is it green? Is it yellow? Again, is this discharge associated with a mass or not? And it is coming from one breast or both bilateral. As well, we have to see if it is from one or both breasts. Is it coming from a single duct or multiple duct discharge? Whether it is occurring spontaneously or after we pressed on the lump or the site. And pressure on a single site or general pressure on the breast. Again, relation to menses. And whether the patient is pre or postmenopausal, and is the patient taking oral contraceptive pill or estrogen. These are important points to consider in any breast abscess. Commonly occur during lactation, and there is feature of acute inflammation, redness, tenderness, hotness, and in duration. The commonest offending organism is one of the skin inhabitants, which is Staph aureus. And in the early stage, antibiotic and analgesia are quite enough, and the patient should be kept fed on antibiotic and breastfeeding. Localized mass with local and systematic signs of infection, then surgical drainage is very important. And if there is an abscess and we drain it, we have to stop lactation for a while from that breast. But the breast, the milk should be expressed, because if becoming gorged with the milk without being evacuated, this will lead to maintenance of infection for a while. Oral contraceptive pills or estrogen may cause clear serous or milky discharge from a single duct, but multiple duct discharge is more common. In the non-lactating breast, inflammatory carcinoma is always considered. More or less give picture similar to mastitis, inflammatory carcinoma of the breast. Finding suggestive of abscess or cellulitis in non-lactating breast are indications for incision and biopsy of any endometrial tissue, if the patient is not lactating or pregnant. By this we come to the end of our talk, and we know now the commonest 5 benign breast conditions. Fibroadenoma of the breast mass, occur in young female. It is freely mobile, not tender, firm. Fibrocystic conditions usually occur in young female, and in most of the cases might be bilateral in our outer quadrants, and it is transient lump that fluctuates in size and associated with pain due to tension within the cyst. Ultrasound is important to diagnose, to differentiate solid from cystic lesions, and painkiller gel, non-steroidal anti-inflammatory drug in a form of gel, and support, very important. Nipple discharge is common, and we have to bear in mind patients with bloody nipple discharge, and because this might be due to intraductal papilloma or carcinoma. Other types of discharge, milky discharge, we have to assess prolactin level if the patient is not lactating or pregnant. Ductictasia is common, might give green or brown discharge. If the lump is palpable, it needs to be excised. And we have in assessment of nipple discharge whether the color of the discharge from one breast or more, or two breasts, from a single duct orifice or multiple, express spontaneous or by pressure, and patient whether taking pills or not, or hormone replacement therapy, and the age of the patients as well is important. Thank you very much.